So if you have the models, or you have like the charts, you could even have somebody go over and like draw for you, like all of that. So on this, go ahead and draw for me kind of where, yeah. Oh, that was really good. It's perfect because now it's not ideal to be uncomfortable, but you're fitting a pretty common pattern. In that, usually the most problematic quadricep muscle is vastus lateralis. It's this one. Right. If we were talking knee rehab from like a ligament tear or some kind of bad injury, if somebody had an ACL injury, they have to go through the whole process, and like so they're not able to bear weight on it as much, they have to brace it more, then they go through the surgery, and then it's trying to get like back up to speed. Or if it's bad knee arthritis, where now the limited mobility and muscle activation, the muscles have begun to atrophy, then they get the replacement. Now leading up to it, it can be important to do this stuff, but especially post that, like all the rehab is going to be about is trying to reactivate these muscles that have been dormant because of the bad arthritis. And the biggest one is vastus medialis. Look how the bulk of the muscle is closer to the knee. See how this has more mass closer to the knee than the other ones do? So this one has to be, along with, like this is the biggest technically one, because this one works at the hip and at the knee. The other ones work only at the knee. So we have of all these crazy structures here, and like the wrapping around, there's all kinds of things where somebody has issues where it crosses the joint lines. There are the ligaments in here. If it was more comfortable for you, you can always take a seat. While I'm yammering away. So we have our muscles, but deeper still the ligaments and tendons. Now, the patella is a strange thing in that it's a floating bone, and it has hyaline cartilage on the posterior surface, and then the space here has that cartilage too. So that can wear out. You can get arthritis of the patella from usually these muscles being so tight over the course of time, they're pulling on the structure, and as it pulls on it, it's not just that it pulls it up, it pulls it and makes it smashed more into that joint surface space. So then every time a person's moving, that's way more abrasive, okay? Massage-wise, your trick with knees is not to work here. It's here.
That doesn't make any sense.
I will show you why it makes sense.
Because you just said those two muscles there work the knee.
They work at the knee, but they're not right at the joint line space. The bellies of the muscle.
They work at the knee, but not the knee.
Yeah, so I will show more officially here. Tendons and ligaments are made of deep fascia. Like they are striated, thick cords that you actually don't want overly loose. You want them pliable. So if we massage along these lines, like I might want to find a way to make sure, like I'm distributing WD-40, synovial hyaluronic acid. I want to make sure I maybe massage over these spaces and give them a bit of a nudge so that they can shift and slide on surface structures. But digging on a ligament or digging on a tendon should not be your first mode of therapy. You want to think of where is the muscle belly of the tendon that crosses over that. So real quick, anatomy lessons with the things here. You got your patella, you got your femur, here's your condyles and epicondyles, there's the tibia and fibula, head of the fibula, and here's your first two main ligaments of the knee. Sorry, tendon-wise, patellar tendon. Usually people will always call it patellar tendon. Technically this is a ligament because it goes bone to bone, and this is bone to muscle. So that's a distinguishing factor always. Ligaments are bone to bone, tendons are bone to muscle. Now ligaments, we have, these aren't named too bad, lateral collateral, sorry, medial collateral, medial collateral, lateral collateral. The acronyms will confuse you because they're all the same. They'll be not all the same, but they all have a C to them. So like there's a MCL, LCL, ACL, PCL. Yeah. But the C's are different. If it's on the outside of the knee, the medial, the lateral side of the knee, not inside, they're collaterals. If they're inside, they're cruciates.
Can you point to it on your body where it is again?
The lateral collateral, if I can find that joint line, I find my fibula, I chase the fibula, I find the joint line, then I know that I'm at least over top of the LCL. Then over here, I'd have to find the epicondyle of the femur, chase that down, and then I'd be on the MCL. Common ones to tear, MCL is more common. So collateral ligaments, medial, lateral, collateral ligaments, so MCL, LCL. Then inside we have the ACL and PCL. So it stands for anterior cruciate ligament and posterior cruciate. The most commonly torn one is the ACL. That's when you hear in sports injuries all the time. Think more of the tibia. If the anterior cruciate ligament is problematic, I should not be able to pull the tibia and feel it slip a lot like that. It should be resistant. So it stops the tibia from slipping forward, and the posterior cruciate keeps the tibia from slipping backward. So the drawer tests are, person sits with their knee bent and you pull on the tibia, and if it's too loose, that might be an ACL. If you push the tibia in like this and it's too loose, it might be a PCL. So I have found them, but I don't get to diagnose it, right? I have found a PCL and I have found an ACL, but I had to go.
Go somewhere else.
This is not moving, right? I don't freak out. I'm like, So, but it's pretty extreme. So when you want to know what normal feels like, but it shouldn't be like, oh, it'll jump out at you, okay? But these are the bad ones. These, since they're not floating inside a joint capsule, they don't usually tear completely, and even when they do, they might be able to heal on their own. It's just like a bracing setup. There isn't a whole lot to do. You brace it, you might have to get a surgical repair here, but the nastier ones are a complete tear of one of these. Because inside of this joint space, they can float around in there, and so they have to harvest it off of one of your own hamstring tendons, so they use a cadaver tendon, and will burrow a hole through sometimes and loop it and recreate it.
That's what my daughter has now.
Yeah. They do her hamstring or cadaver. Cadaver. And it's been all good?
Yeah.
They've gotten better and better at the orthopedic surgeries, so don't poo-poo that too much. Now this one has a tear. That would be a bad deal. Deep to that, what the femur is sitting on, that's the meniscus. It's real common for the meniscus to get something wrong with it too. The knee is one where, in distinguishing edema to a fusion, is a common place. So edema would be like the whole lower leg is swollen and the foot is swollen, right? Diabetic edema, that's a common one, everything. If somebody has a meniscus issue or one of these ligaments tears, then the joint capsule might balloon up with fluid. And it's regional to the joint where there's a balloon. And there's ways to kind of push stuff and see if it bulges, but it would bulge isolated all around the joint line rather than it being the whole extremity. That would be effusion. Effusion is swelling of a joint. Edema is swelling of more of the whole region, okay? Now, all the muscles, the reason to not be working at usually you don't need to be loosening this one up, is part of the story. And that's the one that's closest to the knee. That one needs to be stronger. Everybody needs a stronger vastus medialis, just like everybody needs a stronger deltoid, just like everybody needs a stronger gluteus maximus, all of them. Everybody needs it stronger, and if it's already strong, you need to keep it strong. It's the nature of life. So an appropriate squat and going into full extension, like you want that, any kind of a band work you ever seen anybody doing where they have bands here and then they're going into extension like that. The main focus is usually strengthening this one, not all of these, but you want all of them strong, but it's especially vastus medialis. Now, we have some other crazy muscles too. Up here, look how it does this cool splay. Muscle that way, muscle that way. That's sartorius, which comes all the way over and crosses right over top of the medial collateral ligament. It and two other muscles, gracilis, the most superficial of your adductor muscles, and semitendinosus, and I usually think membranosus too. That's two of your hamstrings. So hamstrings, they split at the knee. This one comes over onto the fibula. This one comes all the way over. But all these muscles, sartorius, gracilis, and semitendinosus, attach right there. Look how those tendons just go right over the whole medial joint line of the knee. So if everybody has an MCL problem or they had a muscle sprain thing here, if it's a medial knee thing, just assume it's all of it. And remember that these muscles all connect in different places. It reinforces a very important part, stabilizes that medial knee. But this muscle is a hip flexor and knee flexor and external hip rotator. This muscle is an adductor, and this muscle is a hip extensor and knee flexor. So it's a crazy thing that can occur here, and people can get tendinitis here. That conjunction is called the pes anserine, and it's listed in your sheet. And why, if you're going to do taping on the knee, might as well cover that area. There's a lot there, and if it's a ligament or a medial meniscus, or it's one of these tendons, you got it covered. Pes anserine, also known as the goose foot. I have not heard that in a long time. So there's sartorius out of the way. On the other side is tensor fascia lata, and it tenses a lot of fascia. Thank you. And stand-up comedy will take you far. So TFL is the muscle that controls the tension and tone of your IT band. And look at the IT band. It is essentially the parallel bracket on the lateral side of the knee to counterbalance this. So they're stabilizing the medial and lateral sides of the knee. Goes directly over. It's a little bit anterior between it and the hamstrings, bicep femoris, the other hamstring. Look how they're sitting right over top of LCL. And how, if one is problematic, how it could cause issues with the others. It's a lateral knee or a medial knee thing. And if either of those are weird, how that would start to disrupt just the whole continuum here related to the patella. Now, the other one, so we remove this guy. Okay. Now look how small that is. That's the muscle belly for what controls all that. And it's all the way up here. I have to find the anterior superior iliac spine and be working here up at the hip to help reduce the tension of IT band down here for the lateral knee. So if I want to work, and sartorius, medial knee, where is its attachment? Up here at the hip. And if somebody's sitting in a car, what's short and what's long? Is this short or long?
Long.
Long.
That's, yeah,
Short.
that's short.
Short. Long. Assume everybody is trapped like this. Okay? So, usually this is where the symptom is, but the cause is here and here. Like using sartorius as a one. So right there, essential. Two muscles that cross the medial line and the lateral line, and they're right there. You can get them at the same time. with a well-placed forearm. You're good to go. Now, another one that lives right there too, though it's a bit more tendinous, is the top of your quadriceps muscles. So how many quads do you have? So this is bicep femoris. So it is on rectus femoris. Bicep femoris, rectus femoris. Bicep femoris is a knee flexor, like your biceps are an elbow flexor. So you have bicep brachii, bicep femoris. Not too bad. Rectus femoris, rectus abdominis. Both anterior and they're on the middle. So rectus abdominis is your six-pack muscle. I use that to help me remember. Rectus and rectus means the middle, and they're both on the anterior side of the body. This one is a hip flexor and a knee extensor. So this is more direct. If somebody's stuck like this, I have sartorius, rectus femoris, and tensor fasciata all tight and short relative to hip flexion, and long related to everything else they do at the knee. And one's on the lateral side, one's on the medial side, and one's right there on the anterior side that connects directly to the patella. So I'm not going to help their knee problems if I don't work at the hip. That's the story. And then there's the rest of them, the three here, that usually just need to be unstuck, especially from rectus femoris. That's a lot of just coming at it on angles to kind of pull things away from my T-band, to pull them off of each other a little bit, and to pull them off adductors. If you look at that line of what sartorius does here, look at sartorius. I remove that. Look at all those tubes. Okay, that's the femoral artery, nerve, all that good stuff. So finding a way, I don't want to be smashing too directly along that line, but if I can find a way to pull these structures away from this valley, then I'm going to certainly help with nerve conduction and circulation. This is also a primarily kind of lymph channel that gets used. It's not too crazy, it's sideline, get those adductors, pry them away. That's where supine can be beneficial, because when we turn a person's leg out, and I come along, whoop, there was a glute. I go along this.
I hate it when that happens.
I know. But I'm working, I turn their leg in, I'm trying to work on getting stuff pried off IT band. I turn them more central, I'm thinking getting rectus femoris pried off. I turn them more lateral. I'm not going to be worrying as much about vastus medialis trying to turn its tone down. I'm going to come on a line and not try to dig into this valley. I'm going to be trying to push adductors away from the anterior quadricep group. That will ideally have the effect we're looking for, because we have to remember these things come down here too. All right, that was the yammer on the knee. The biggest thing to take away from it is you can never affect the low back or the knee, the low back. I said it right. You can't really help the low back or the knee without working at the hip. And if you don't get good and comfortable at how to navigate working on the hips, you're going to be missing the ability to help tons of people, because that's where so much more structures related to adaptation occur. The knee is just a hinge joint. It doesn't do a whole lot. So if the ankle and foot aren't working right, more stress here. The hip isn't working right, more stress there. Symptom manifests here. You got to think predominantly here, but then there's also all the stuff that we even talked about with ankles and